going to talk about ductal carcinoma in situ. And what we've tried to do is start the evening with an overview, kind of back to basics, DCIS, and then we're going to follow that with two very specific parts of the management of DCIS, and in particular, topics that are really very hot at the moment. So for the back to basics talk, I'm going to introduce David Gorry, who is nearly leaving us from Tygerberg as our registrar. He's passed his exams. Can we give him a clap? No mean feat, and should you ever fall ill or need a surgeon in Potchefstroom, I think that's how you say it, then David will be there ready to supply any surgical needs you have. But David, it's really been a pleasure having you. For his MEd, he did it in the Department of Breast and Endocrine Surgery, and we did a feasibility study on a nurse's screening program. It was really very fascinating, and I don't think we got the results that we were expecting, but it really was quite interesting from a number of points of view. So David, thank you, and I'm going to hand over to you.
Thank you everybody for this opportunity that was bestowed upon me to have a little chat about a topic that I think, looking at the caliber of the audience, they probably know more about than what I do. Also, what I'd just like to say that Jenny has the ability to tell you to do stuff, and you can't really say no or refuse. So, but yeah, I do appreciate the opportunity that was given to me. All right, so ductal carcinoma in situ, back to basics. What essentially we will be covering is looking at essentially what is the scale of the problem, what it actually is, looking at different classification system and features used traditionally. I have got risk factors in there, but I'm not going to speak too much on that. And then having a look and see what our imaging features are common to the diagnosis of DCIS, then touch a bit on treatment guidelines and whether or not DCIS should actually be treated or not. This is just going to be a really brief overview, touching on a few of those aspects that some of my other colleagues will also be elaborating on. So essentially, when one looks at DCIS, we discovered that once mammographic screening was introduced around about the 1980s, that there was a significant increase in the diagnosis of ductal carcinoma in situ. So essentially, as the biggest risk factor for DCIS is related to screening. We noted that DCIS is actually accounts for about between 18 to 25% of all newly breast carcinomas, be that DCIS or invasive breast cancer. And so the challenge really is that we would like to diagnose it earlier, treat it, and therefore the reason for that is because about 20%, some literature up to 53% says that it will develop into invasive breast cancer. And as a result, this is really quite a big topic, and it's something that is very prevalent. So what actually is ductal carcinoma in situ? So that if you read any definition, and normally it would say that it's a heterogeneous group of proliferative cells that is confined to the ducts and the lobules of a particular breast unit that doesn't really go beyond the basement membrane. So what it actually really means is it is a cancer that is confined to the breast and has not got an invasive component to it. It is essentially a non-obligate precursor to invasive carcinoma, and that is what distinguishes it from invasive breast cancer. As you can see by the pictures that I have there, just to kind of demonstrate what it will look like on a microscopic level. So when we look at trying to classify ductal carcinoma in situ, we have some, traditionally, the way it has been classified is to look at essentially three things that either can be used on its own or a combination of the three. So one would be its growth pattern. The second would be sort of the cellular atypia that you would find, defining it as a low grade or high grade. And thirdly, the degree of necrosis that you get. And as I said, it can either be used on its own or can be a combination of the three, depending on which classification system you want to use. So when one looks at the growth pattern, one will then realize that you have the two main groups essentially would be your comedo and your non-comedo type. Comedo denoting to the fact that it's got an element of necrosis, which is usually what you would see when one does a mammographic screening, that you get this calcifications that form as a result of this necrosis. On your non-comedo type, you will then have the different, mainly four types, but there are other lesser significant types that looks at the type of what you'd find histologically in terms of its growth pattern, and that would be then your cribriform type, your papillary type, micropapillary type, and your solid type, and you get the lesser ones like a signet cell type as well. And then so that really looks at the growth pattern. The important thing about seeing these growth patterns on the histological slide also helps us to decide whether this might be a high grade or low grade. You often see that with DCIS, high grade DCIS, they're usually of the comedo type, whereas your non-comedo is usually of a low grade type. When one looks at the cellular atypia to help define or help classify them, you depending on which system that you want to use, the Legio system looks at purely the cellular atypia, being defined as either low grade, intermediate grade, or high grade. When one combines those grades together with or without the presence of necrosis, you then make use of the Fanasa classification. And then the Europeans then went and put all these together and define it like we do a lot of other cancers, as either being well differentiated, intermediately differentiated, or poorly differentiated. But I think by and large, when you do get a pathological report, it either gets reported as being high grade, low grade, or intermediate grade, with or without the absence or the presence of necrosis. As mentioned earlier on, the diagnosis or the suspicious of a diagnosis of DCIS is made on imaging. As you can see there, I've mentioned three imaging modalities that is quite commonly used in breast and endocrine. But in as far as diagnosing DCIS is concerned, digital mammography is essentially the cornerstone of the diagnosis. I will elaborate more as to what the findings of those mammographic findings will be. When one looks at ultrasound and MRI, it's really supportive. It's not sort of our primary form of diagnosing these, but merely as supportive, and also perhaps to rule out other causes. I'll mention a little bit more about MRI and what the indications of MRI are in as far as DCIS and as opposed and for invasive breast cancer as a group. So what do we normally see when we do a mammographic screening? Essentially, there are two big groups, if you will, that we can classify the findings in. Those that develop with microcalcifications, and those who don't have microcalcification, but have other features associated with it. And then when one looks at the microcalcifications, you often find that they are usually within a certain pattern or distribution or of different shapes and sizes. And this really makes out the majority of how these imaging features are found in DCIS. Then, of course, without microcalcifications, you have other features. This is just a nice overview that I think is useful if there are, guys that are still preparing for the exams, just to kind of have a look at and give you a nice overview as to how one can approach it. In a little bit more detail, when one looks at the microcalcifications that you get in DCIS, you can either look at two things: the distribution thereof, as well as the morphology. And so we often speak of things like pleomorphic calcifications or fine granular calcifications. And it's important when we see these, obviously one can get that in invasive carcinoma as well. But in as far as the DCIS is concerned, when one sees these features, the importance of recognizing them can also helps us to decide whether this might be high grade or low grade. So, for example, if the most common pattern that you would then find would be sort of, in as far as distribution is concerned, usually this linear pattern that you get with fine granular type of microcalcifications, which, by the way, is said to be less than 2 millimeters in size. And so when you see that, you tend to think that it's probably of low grade. When you see these more coarser amorphous type of morphological appearance of and pleomorphic type of calcifications, then one would be more concerned about high grade. And of course, other than the specific type of microcalcification, one also want to look at how many sort of groups of these appear in the breast, because those have got treatment implications. You know, whether you want to do breast conserving therapy or whether you want to do mastectomy for the patient, or some of the treatment options that we will allude to later on. So I think those are the two main things of a microcalcification to look at the distributive pattern as well as the morphology to help us make the diagnosis or have a suspicion thereof. So like I said earlier on, not all of them present with microcalcification. Up to about 30% of them will then present with either what is known as an architectural distortion. So you obviously have to compare the two breasts like you would do any other mammography and look at the different views, your craniocaudal and unilateral oblique. It's very important to compare the two sides. And then, of course, you can get a mass nodule with those hyperdense lesions, which are irregular in shape and size. And then, of course, asymmetry in the breast. So any abnormalities like that can obviously make one suspicious of thinking of DCIS. So I'm just going to briefly mention, like I said, the ultrasound features, which is mostly sort of supportive. Again, you can get microcalcifications or you can non-calcified lesions. One can get hypoechoic masses, you can get ductectasia, irregular ductectasia. And so these are, it's actually more non-specific signs that you see, which is not as sensitive as you would get when you're using a mammogram. MRI, as we all know, MRI is it's not really freely available. It's expensive, but there is value in doing MRI. Of course, if one wants to have surgical planning, it's obviously not essential for pre-surgical planning, but it can aid pre-surgical planning in the detection of occult breast lesions, especially in the contralateral breast. One thinks of females with dense breast, where mammogram and ultrasound, well, especially mammogram, might not be as sensitive, where then MRI can be of great value. But we also know that the use of MRI tend to overestimate and overdiagnose these lesions, which might let us treat women that might otherwise not have needed treatment. So the last two modalities, really supportive and really individualized, where mammogram might not be sufficient. Right, so moving on to an overview of the treatment guidelines for DCIS. So essentially, your treatment options are the treat or you observe. There's, which I'll speak a little later to you about. When we decide to treat them, our treatment options would be to do breast conserving surgery. That will then essentially be a wide local excision with radiation in a small percentage of patients with that might have a low-grade DCIS or clear margins. Some radiation can be maybe omitted, but by and large, breast conserving surgery and radiation goes hand in hand. Then, of course, the other option would be to perform a mastectomy for these patients. Then and then observation as a non-surgical management. The two blocks next to that, sentinel and lymph node biopsy. is to be considered. I'll speak a little bit about it, so I'm just mentioning it in the slide. As you can see, it is not part of the sort of main algorithm that I have on the right-hand side, but it is something that has to be considered in certain conditions or under certain circumstances. And then, of course, adjuvant endocrine therapy, that I'll also just mention a few things, but I think there is a speaker that's probably going to elaborate a lot more on that. I'm just giving overview. Right, so breast conserving surgery, we all know that in invasive carcinoma, under quite strict conditions, size of tumor to breast ratio, and various other factors will determine whether one can offer somebody breast conserving surgery in invasive carcinoma. The concern, obviously, in somebody with DCIS is the concern of positive margin in a lesion that might not be that well defined mammographically or even clinically. But the criteria would essentially be that you, as opposed to invasive carcinoma, where you only need to have or not have tumor and ink, with a DCIS, we want a 2 millimeter tumor-free margin. Of course, again, you need to have for cosmetic purposes or medical reason, you need to have a good tumor to breast ratio in order to consider that. I've mentioned two other criteria: the willingness of a patient to receive radiation therapy, which is something that has to be considered. Like I said, not everybody will not need radiotherapy, but certainly when you do consider breast conserving therapy, you need to have a willing patient that is willing to want to have radiation. And of course, you know, as you all know, that in receiving radiation therapy, that the way the machine is designed, it has a capacity, a maximum capacity. So, and we're dealing with a population that is obese. And so somebody, obviously, if they are not able to fit into the machine to get radiation therapy, that you'd probably want to then consider offering them a mastectomy. The advantages of offering somebody breast conserving surgery is well known to us. There's less morbidity, there's better cosmetic outcome, and one potentially prevents over-treatment in offering somebody a mastectomy that with the obligatory sentinel lymph node biopsy in most of them, and we all know the side effects of those. However, we do see that the risk of recurrence, the incidence of local recurrence, is higher with breast conserving surgery compared to mastectomy. But also on the opposite side of the spectrum, the overall mortality and all-cause mortality is not really affected, despite the increased risk of local recurrence offered for breast conserving therapy, which makes it a good option to offer. Mastectomy, cure rate of more than 98%, as quoted by certain studies. Of course, the recurrence rate compared to breast conserving surgery, as mentioned before, is much less. And then, yes, not everybody, unfortunately, can have breast conserving surgery. That is somebody who's got multiple synchronous lesions, or one previously would speak of multifocal or I've even forgotten the name, because we use multiple synchronous lesions, because I think it's much more, it's a better way of probably describing these lesions. That also being said, that if you do have multiple lesions within a confined space, it does not preclude the person from getting a breast conserving surgery. The caveat obviously being that you need to get a 2 millimeter margin. Then, of course, we have to accept patient's choice in the matter. And there's some women who feel that they want to reduce that risk, significantly by opting for a mastectomy. And I think that is something that if it's their choice, should be offered to them. So that then brings me to the issue of doing a sentinel lymph node biopsy. Because we see that in up to 20% of the DCISs that come back following core biopsy or following excision, there's an upscaling of up to 20% of patients coming back with invasive carcinoma, and therefore it makes sense then in these treatments to offer them a sentinel lymph node biopsy, because you are disturbing the lymphatics, and as a result, this is your best chance of doing a sentinel lymph node biopsy. If you're going to do it afterwards, then obviously if it comes back as being positive, then you have to offer the patient a second procedure, and so therefore it is it should be considered in mastectomy. And I think I've said on this particular slide just what I mentioned previously about the sentinel node biopsy. Right, radiation therapy, as mentioned earlier on, it is radiation therapy is given with breast conserving surgery. There are various trials, and we know the famous NSABP17 trial that has shown a significant reduction in local recurrence by offering patients with either DCIS as well as invasive breast cancer with breast conserving surgery, radiation therapy. Again, as mentioned, it unfortunately does nothing for your overall survival as well as all-cause mortality. We all know, like most things, that it has its side effects, and therefore it can be considered, you can consider omitting them in advanced age. So there's probably no point in offering somebody over the age of 75 radiation therapy, and as well as somebody that's got other comorbidities that might make it intolerable for them or to receive radiation therapy, and things like connective tissue disorders, etc., being relative contraindications to or giving somebody radiation therapy. If you are also going to consider somebody with a luminal tumor, a chemotherapy, then one could possibly consider omitting radiation therapy. Right, a few words on adjuvant endocrine therapy. Up to 75% of DCIS expresses estrogen with or without progesterone. We have seen in several trials, the very well-known B24, the UKZN, and the DCIS trials have shown that giving endocrine therapy does reduce the risk of ipsilateral as well as contralateral invasive breast cancer in these individuals. And the endocrine therapy that we do offer them, premenopausal women receive tamoxifen, and postmenopausal women, we put them on an aromatase inhibitor with comparable efficacy. But we also are quite well aware of the fact that our aromatase inhibitors have got quite a significant amount of side effects. These are all of which is these musculoskeletal aches and cramps and pains that is quite unbearable to this population. And of course, your aromatase inhibitors, so your tamoxifen with the increased risk of DVT, etc., needs to be considered. So yeah, in all patients who has an ER positive tumor, when breast conserving surgery is considered, and in patients who's had a mastectomy, in which you want to prevent recurrence in the contralateral breast, and we usually give it for about 5 years. But like I said, I do think somebody's going to speak a little bit more on endocrine therapy. Then lastly, do we need to treat DCIS? Just a few words. I don't want to elaborate too much on some of the evidence that's out there, but there's this well-known trial called the low-risk trial, looking at women that over a 10-year period, what they've done, it was a prospective randomized controlled trial that looked at women that had low-grade DCIS diagnosed. They all had a breast conserving surgery with or without post-operative radiation therapy. They were followed up after 10 years, and those who met the criteria for the low-risk criteria, being over the age of 46, having microcalcifications on mammography, as well as having low-grade DCIS confirmed either on biopsy or on the excision specimen or on the vacuum biopsy. If they've met those criteria, they found that those individuals had a much lower recurrence of ipsilateral breast cancer, and therefore it is postulated that people with the DCIS, low-grade DCIS, could possibly be managed with observation. The COMET and the LORD trials, I believe, is still ongoing, and essentially also randomized controlled trials. It's now sort of randomizing women with low-grade DCIS into either receiving surgery, whether that be breast conserving surgery or mastectomy, or randomizing them to the other group to just observation. And essentially the primary endpoint is to look and see whether they develop ipsilateral breast cancer. And I believe the law trial the results should be out around 2029. But so far the low-risk trial has shown some good overall outcome, long-term survival recurrence in those individuals who were of low risk. Yeah, that is essentially in a nutshell all I wanted to say about DCIS.